to, and don't forget to speak loudly.
Well, hello again. Obviously, you all know that I'm interested in Hodgkin lymphoma at this particular point. I'm going to try to not to be all that redundant, but there'll be some redundancy. So I'm going to discuss the results of PD-1 blockade with Pembrolizumab in patients with classical Hodgkin lymphoma. All these patients have previously failed Brentuximab Vedotin. As you just learned, classical Hodgkin lymphoma has a paucity of Reed-Sternberg cells, which is the neoplastic cell in Hodgkin lymphoma, but there's a brisk mixed inflammatory background. Many of these cells are T cells, and they express PD-1, and PD-1 is inhibitory in classical Hodgkin lymphoma. It is very interesting, the story about 9P224 and its resultant overexpression of both PD-L1 and PD-L2. In addition, half of Hodgkin lymphoma patients have been exposed to EBV. That in itself is probably not prognostic, but it does upregulate PD-L1 and PD-L2. In fact, it's unclear to me if you even need to stain Reed-Sternberg cells for PD-L1 and PD-L2 because it's almost uniformly seen. So Pembrolizumab is a humanized monoclonal IgG4 antibody against PD-1. There's a high affinity for the receptor. It's dual blockade of both PD-L1 and PD-L2. PK dosing is evolving, but it can be given every 2 to 3 weeks. It's demonstrated a wide variety of activity in solid tumor. As you know, this agent was approved in melanoma this year. The doses were escalated up to 10 milligrams per kilogram with very little side effects, which was the reason that you can see in our study we used 10 milligrams per kilogram. That will not be the dose that will be moved forward. It will be a dose that's analogous to nivolumab. But this study included patients with classical Hodgkin lymphoma. They were either transplant ineligible because of primary refractory or progressive disease. That's a very poor patient population. Or the patients failed a stem cell transplant. All the patients failed Brentuximab Vedotin. Hodgkin lymphoma patients usually are in good shape. They have good performance status. Both of these drugs, in fact, all the checkpoint inhibitors have been associated with some mild autoimmune phenomena and endocrinopathies. And patients with interstitial lung disease were excluded, specifically patients with a history of gliotoxicity or radiation pneumonitis probably should not get a checkpoint inhibitor. Patients received Pembrolizumab. Those patients who had evidence of responsive disease could stay on study until they achieved no more clinical benefit. They could be taken off study if necessary for a transplant. Patients with progressive disease were discontinued. Baseline characteristics. The follow-up of this study is somewhat shorter than nivolumab. 29 patients will be discussed today. The median age is 32. Remember, the median age of Hodgkin lymphoma in the United States is 28. Patients had a good performance status. Number of prior therapies were greater than 5 and more than half. All the patients failed Brentuximab Vedotin, or Brentuximab Vedotin failed the patient, whichever you believe is the right terminology. And the majority of patients failed a stem cell transplant. Concerning adverse events, extremely well-tolerated treatment. A few grade 3 events. Actually, the patient who had hypoxia did not have pneumonitis. One patient had axillary pain that was severe in a tumor site, probably related to tumor inflammation. But very few events. Here's the waterfall plot, which is really quite good. Almost all the patients had some evidence of tumor shrinkage. The complete responses in red, partial responses in light blue, stable diseases in purple. This is anti-tumor activity based upon investigator review. These are the cohorts, kind of divided between transplant ineligible and transplant eligible. The overall response rate is 66%. 6 patients had a complete response based upon PET imaging. A number of patients had stable disease. I actually think stable disease is quite important with these checkpoint inhibitors. I'll show you that in the next slide. But the clinical benefit rate is 86%. The reason I think it's important is that some of the patients who've been on the longest treatment actually have stable disease. In fact, the top person has stable disease, had tumor shrinkage by about 1/3, and this patient is on, continues to get therapy. The median duration of response has not been reached on the study thus far. 20 patients of the 29 patients are still on treatment. So in conclusion, pembrolizumab, I believe, has excellent activity in patients with heavily pretreated Hodgkin lymphoma and a cohort of patients who all previously failed Brentuximab Vedotin. The CR rate was 21%, the overall response rate 66%, the clinical benefit rate 25 of 29 patients. I think the safety profile of these drugs are really quite good. Very little grade 3 or 4 toxicity. Among the patients that we had that we did stain for PD-1, 100% of the samples did stain for PD-1. I do believe that the results of this study should implore really both companies to continue research with PD-1 inhibitors in a variety of subsets of patients with classical Hodgkin lymphoma. Thanks for